The topic for the today's class is acute suppurative otitis media, that is ASM, right? So I will be discussing the topic under this heading like definition, the subgroups of ASM, etiology, risk factors, route of spread, pathogenesis, clinical features, investigation, the various DDs, the management, and the clinical outcomes of acute suppurative otitis media, right? So first is the definition. What is ASM? It is defined as rapid onset inflammation of middle ear cleft. Middle ear cleft include middle ear. Anteriorly it is the eustachian tube opening. Posteriorly it is the editus and the antrum. So it is acute and the rapid inflammation of these structures, that is middle ear, eustachian tube, editus and the antrum. This is known as acute suppurative otitis media. It is infective in origin, associated with middle ear effusion, and it is with the varied collection of signs and symptoms. So it is defined as rapid onset inflammation of middle ear cleft which is infective in origin, associated with the middle ear effusion and with the various signs and symptoms, right? So what are the subgroups of ASM? The first one is sporadic variety. Sporadic means it is infrequent isolated event which is usually associated with upper respiratory tract infection, right? Second is resistant. What is resistant? Means which is not responding. Means the persistence of signs and symptoms even after 3 to 5 days of antibiotic treatment. This is known as resistant variety. The third variety is persistent. Persistence is persistence or recurrence of symptoms and the signs within 6 days of finishing the treatment. So what is the difference between resistant and the persistent variety? In the resistant variety, there is, even after the antibiotic treatment is going on, there is no improvement, right? But in the persistent variety, the antibiotic course is finished and again there is symptoms. It is known as persistent variety. The fourth variety is recurrent, which is defined as 3 or more episode in last 6 months or 4 or more episode in last 1 year period. So these are the four varieties: sporadic, resistant, persistent, and the recurrent. Next is etiology. So ASM it is multifactorial and it is combination of microbiological agent, anatomical factors, environmental factors, altered host defense, and genetic factors. These are multifactorial etiological agents that leads to acute suppurative otitis media. We'll discuss one by one. First is microbiological agents. So what are the pathogens? It may be bacterial, viral, and the fungal. In the bacterial one, it can be Streptococcus pneumoniae, H. influenzae, and Moraxella catarrhalis. In the viral, it can be respiratory syncytial virus, influenza and parainfluenza, rhinovirus, adenovirus, and enterovirus. In the fungal, it can be aspergillosis, aspergillus, or candida, right? So it can be bacterial, it can be viral. These are the most common variety. Fungal is very, very rare. And whenever there is upper respiratory tract infection which is viral in origin, it is superseded by bacterial invasion and that leads to suppurative otitis media, right? Next, etiology is anatomical factor. Whenever there is infection inside the ear, nose, throat area, like whenever there is tonsillitis, adenoiditis, rhinitis, sinusitis, or there is tumors of nasopharynx, cleft palate, and any exanthematous fevers like measles, diphtheria, whooping cough. These are the factors that leads to that makes the child prone to acute suppurative otitis media. Any infection in these areas, it can lead to infection inside the middle ear and acute suppurative otitis media. The next one is genetic and syndromic. This variety is very important because these are the patients who are potential candidate for recurrent variety of acute suppurative otitis media. It include The mothers with blood group A. Atopy means it is tendency to have allergic conditions like bronchial asthma. Then we have Turner syndrome, Down syndrome, and the patients of cleft palate. These are the patients who are more prone to not simple variety of ASM, it is recurrent variety of acute suppurative otitis media. Next is immune factor. It includes low levels of immunoglobulins, that is IgG2, delayed maturation of anti-pneumococcal antibodies. This is very, very important, right? Because these are the patients in whom we usually recommend the vaccines, right, against the streptococcus pneumoniae. Then we have defective complement dependent opsonization, and there can be aberrant expression of various genes like tumor necrosis factor gene or mucin gene, right? So the genetic factors, the syndromic ones, and the patients with immune factors, these are the patients who are prone to have recurrent variety of acute suppurative otitis media, right? Now, what are the various routes of spread of infection to the middle ear? In which the most common variety is, the most common route is station tube, which can be through the lumen of the tube or through the lymphatics, which may be subepithelial lymphatics or peritubal lymphatics, right? The spread of infection to the middle ear, it can be through the lumen of the tube or through the lymphatics, which can be subepithelial lymphatic or the peritubal lymphatics. This line is very, very important. The tube, the station tube in the infants, it is shorter, it is wider, and it is more horizontal. And these factors makes the child more prone to acute otitis media. So what is the significance of this line? We, because of this factor, the breastfeeding mothers, they are advised to feed not in horizontal position, because there are more chances of getting the infection to the middle ear. So we advise the lactating mother to feed their child in reclining position like this, not in horizontal position, right? So this is one example through which is very, very common problem with the general public. They clean or they use these earbuds, which can lead to damage to the tympanic membrane perforation, and which can lead to entry of the infection inside the middle ear, right? And thus leading to otitis media. So what were the routes? Most common is the station tube. The second common is external ear through the tympanic membrane perforation or through the ventilation tube, right? Or we can say through the grommet that we place in patients of acute otitis media or in patients of otitis media with infusion. This is example, tympanic membrane perforation, right? And third is hematogenous route, which is not very common. This is very, very, very important. The direct invasion, which is the propensity of RSV virus, that is respiratory syncytial virus, and how it leads to direct invasion. It affects cell-mediated immunity. The RSV, it affects cell-mediated immunity. However, the influenza virus has the property of alteration of neutrophil function. So in the variety of direct invasion, we have two things. One is RSV virus, and second we have influenza virus. The RSV virus, it causes direct invasion by affecting the cell-mediated immunity, and the influenza virus, it causes the alteration of neutrophil function and thus causes direct invasion inside the middle ear, right? So again, I'm repeating the routes. The first route is station tube. The second one is external ear through the trauma. Then we have hematogenous route, and the last, which is very, very important, it is direct invasion, because we may get many patients inside the coming to OPD with normal station tube. There is no history of trauma, and the blood is sterile, means blood culture is sterile, but still the patient is having acute otitis media. The cause can be direct invasion by the virus, RSV virus. Now, in the pathogenesis, there are 5 stages of acute suppurative otitis media, right? We have stage of tubal occlusion, then we have pre-suppuration, then suppuration, the resolution, and the complication. We'll take one by one. In the stage of tubal occlusion, because of any infection inside the upper respiratory tract infection, there is edema and hyperemia of station 2. And the station 2 has two ends. One is nasopharyngeal end and the second one is the middle ear end. Okay. So whenever there is infection inside the oral cavity or upper respiratory tract infection, there is edema, hyperemia of the station 2, and it causes the blockage of the nasopharyngeal end of station 2, right? Because of the blockage, there is absorption of air inside the middle ear and it leads to negative intratympanic pressures, right? The pressure inside the middle ear becomes negative and this leads to retraction of the tympanic membrane as shown in this diagram. The TM is retracted, right? And what are the features of retracted tympanic membrane? As we can see, the cone of light is distorted, the lateral process of Malleus becomes prominent, right? And we can see the retracted tympanic membrane, right? So what are the clinical features of patient at this stage? That is stage of tubal occlusion. Because the TM is retracted, the patient complains of decreased hearing, mild earache, but there is no fever because there is no invasion by the uh, bacteria or the virus. So it is only deafness or earache, but there is no fever. In the science, as I have already explained, the TM will be retracted, handle of Malleus becomes more horizontal, and this is also known as foreshortening of Malleus. Means it is not truly shortened, but it appears shortened. The prominent lateral of Malleus and the distortion of light reflex, right? So whenever at this stage, if you do tuning fork test, the patient will have conductive deafness. Although it is not recommended in patients of ASM, we never we hardly do this tuning fork test in stage of tubal occlusion. What will be the finding? It will be conductive deafness. So in the stage of tubal occlusion, the tube gets blocked, there is negative middle ear pressure and there is retraction of tympanic membrane. So the main finding will be decreased hearing with mild pain, but there is no fever. In the second stage, stage of presuppuration, when the tube blockage is prolonged, there is invasion by the pyogenic organism, right? And because of this, there will be hyperemia, congestion, and the middle ear effusion, and it leads to congested tympanic membrane, right? As it is seen in this diagram, tympanic membrane is congested, and we can see these fine vessels, right? This is known as cartwheel appearance of tympanic membrane, right? We can see the radial vessels, small vessels. This is known as cartwheel appearance of tympanic membrane. Now in the clinical features, the symptoms are, because there is tympanic membrane is retracted, the child will have marked earache, decreased hearing, and there is invasion by the pyogenic organism. The patient will have high grade fever and the restlessness, right? In the sign already explained, the tympanic membrane will be congested and there is cartwheel appearance like a cart. We can see the thin radial vessel. This is known as cartwheel appearance. These are few signs which are very important in relation to ASM. So the first sign I explained is it is cartwheel appearance. Next is stage of suppuration. In this, in the previous stage it was invasion by the organism, right? And the next there will be, because of the organism, it will lead to extensive pus inside the middle ear as well as in the mastoid, right? And because of the collection of middle ear, the tympanic membrane will be bulging out. I can show in this diagram. So because of the tympanic membrane is congested and it is bulging, again same symptoms, severe pain, deafness will increase. This is very important. In this stage, patient may have very high grade fever, 102 to 103 degree Fahrenheit, and along with that, patient can have vomiting and even seizures, right? And in the signs, this is the diagram. We can see this is the tympanic membrane which is bulging, and this is the sign. Again, this is very important sign. It is yellow spot. This is collection of pus behind the tympanic membrane. And because of the continuous pressure by the pus, there is protrusion of the tympanic membrane, right? Because of destruction of fibrous layer, and that it leads to a protrusion which is known as nipple sign, right? And this is the sign of impending perforation in case of acute suppurative otitis media. So what are the classical sign in this stage? It is, one is yellow spot and the second one is nipple sign, right? Symptoms: severe pain, high grade fever, vomiting, and even seizures can be there, right? And if you ask X-ray mastoid, there can be clouding of mastoid hair cells, right? Although it is a clinical diagnosis, X-ray mastoid is rarely done, but if it is done, it will show clouding. The last stage is stage of resolution. It is not last is stage of complication. Stage of resolution. In this, the tympanic membrane will rupture, as shown in this picture. The tympanic membrane ruptured from this side. The pus will come out. The pressure will be released, and the child will feel better. Fever will decrease. The pain will decrease, right? And the discomfort will decrease. And we can see the TM is not bulging, right? Because the pus is released, the classical picture of congestion and bulging the tympanic membrane is not there in this picture, right? So we can see the pinhole perforation in the stage of resolution, right? So earache is relieved, fear comes down, child feels better. In the signs, we can see the perforation in the tympanic membrane and the congestion of the tympanic membrane will come down, right? The last stage is stage of complication, which is not seen in every case. What are the two scenarios in which we can see this stage? One, if the virulence of the organism is very high. Second, if the host immunity is low, right? It can lead to disease spread beyond the middle ear, and it can lead to various complications. So it is not necessarily that we get complication in CSOM. We can get complication even in ASOM. So what are the complication? Again, the same. It can be extracranial or intratemporal. That is perforation of tympanic membrane. It is acute mastoiditis. Petrositis can be there. Facial paralysis, labyrinthitis, right? In the intracranial, it can be again meningitis, brain abscess, subdural abscess, hydrocephalus, or the sigmoid sinus thrombosis. What is the mechanism behind complication of ASM? It is the mainly because of the pressure, edema because of the pus. Edema over the facial nerve, it leads to facial paralysis. However, in CSM, the main mechanism behind all the complication, it is the enzymatic destruction of bone, right? And the hyperemic decalcification. But in ASM, the main reason behind the complication, it is pressure, edema. So that is why in case of ASM, because of the impending complication, we do maryngotomy, that is release of the pressure and release of the pus is done, that is known as maryngotomy. Now there is one term which I discussed, recurrent ASM. Now what is the cause of this recurrent ASM? This slide is very important, and this is asked in DNB exam also. It may be asked as a separate question, the role of biofilm, right, and intracellular infection. What is biofilm? Biofilm is, it is cluster of bacteria which is embedded. But there are some certain bacteria that release the polysaccharide matrix, and they get embedded inside they hide themselves inside this matrix, and that makes them resistant to routine antibiotics and the host defense mechanism. The most common example is Streptococcus pneumoniae and Moraxella catarrhalis, right? While the H1N influenza, it makes itself safe and resistant to antibiotics because of its property of getting intracellular, right? Again, I'm repeating the biofilm. This question is very important for DNB theory exam. It may be asked as a long question. Biofilm, it is a defensive mechanism by certain bacteria. They embed themselves or they hide themselves inside a polysaccharide matrix secreted by themselves, and it makes resistant to the routine antibiotics and the host defense mechanism. Now, what is the method to examine? We cannot see this biofilm on naked eyes or with the otoscope or in the routine culture. So what is the method? These can be examined or these can be diagnosed with the help of TEM, that is transmission electron microscopy, or CLSM, that is confocal laser scanning microscopy, right? These are the two methods, and this is again asked in DNB practical. What are various methods of diagnosing biofilm? It is transmission electron microscopy and laser scanning electron microscopy. This is picture of transmission electron microscopy, and we can see the Streptococcus pneumoniae inside the biofilm, right? Please prepare your short note on biofilm. This is very important in theory as well as because we may get some patients of even chronically discharging here which are not responding to your routine IV antibiotics, which are negative on culture, right? Post of mastoid cavity, the role of biofilm is very important, and it is very important to address this biofilm, right? Now, what are the clinical manifestations of ASM? It can be specific, again discussed already. It can be otalgia, ear pain, ear discharge, decreased hearing, dizziness, hearing loss, and crying. In the non-specific can be fever, vomiting, irritability. There can be refusal to feed. This is very important. Refusal to feed. Like if any patient, small child comes to you in OPD, and the mother gives history that child is crying, excessive crying, refusal to feed, and he or she keeps hand on the ear, that gives history that points towards there may be acute otitis media, right? Now, what are the investigations that can be done to diagnose this condition? The four very important, again, I am telling is acute otitis media. It is a mainly a clinical diagnosis. The most important investigation that is done in OPD itself, it is otoscopy. What are the points we have to see on otoscopy? It is color of tympanic membrane, which may be pink, which may be yellow, which may be red. In acute otitis media, it is usually red. Then degree of opacification, because of the fluid, normally it is translucent. Because of the fluid, it can be semi-opaque or opaque. The position, it can be neutral, it can be retracted. Retracted is usually seen in otitis media with effusion, and bulging it is seen in acute otitis media. Then the mobility, it may be decreased, presence of air fluid level, and presence of redness. So these are the points which are to be examined on otoscopy. So in the nutshell, we can say the TM which is congested, the TM which is bulging, and hypomobile TM, it is quite diagnostic of acute otitis media. Clear? So otoscopy is the first. Second, on the basis of otoscopic picture of tympanic membrane, we can differentiate whether this is acute otitis media and this is otitis media with effusion. The main difference between these two entities is, in this entity, the fluid behind the tympanic membrane, it is infected, it is pus, right? But in otitis media with effusion, the fluid behind the tympanic membrane is sterile, it is not infected. This is the main difference, right? And second main difference between the two is, in AOM, the tympanic membrane, it is usually bulging, it is usually bulging, but in otitis media with effusion, the TM is mainly retracted, right? On the basis of color, the in acute otitis media, the TM is mainly red, but in OME, because the fluid is sterile, there is no infection, the TM is either gray or it is pink. Other features are almost same. In both the variety, the TM is not translucent, the light reflex is distorted, the blood vessels are usually seen, the fluid levels, of course, because in both the condition there are fluid, right? So it is almost same. So main difference is, in AOM, the TM is usually bulging and it is red. In this, it is usually retracted and it is not red. The next investigation we can do in OPD is this tympanometry or impedance audiometry, right? It is used to establish the medullary effusion. However, it is very difficult to get done in pediatric patients, and it is very difficult to perform in the patients with earache or otalgia, right? So it is usually not done because ASM, it is usually a clinical diagnosis, right? For theoretical part, we can write it as tympanometry, but it is usually not done in case of acute otitis media. And in uh, patient with effusion, we usually see either B curve or the C curve, right? A is normal. AS is in patients of uh, fixation, ossicular fixation, right? In case of otosclerosis, D for discontinuity, we see in ossicular discontinuity. B and C usually they are seen in medullary effusion and in patient with the retracted tympanic membrane. The last, which is not done, it is tympanocentesis and culture. It is the invasive process, and it is not very we can say it is not yielding test, because in most of the cases it is usually bacterial, but in some of the cases the etiology can be viral, right? And the culture will be negative for the bacteriology. And the second point, there false negative culture because of the prior use of antibiotics. That makes this tympanocentesis and culture a not a useful investigation for patients of acute otitis media, right? The next investigations that we discussed in cases of genetic, syndromic, and immune patients, we can go with the real-time PCR for the PLY gene for Streptococcus pneumoniae. We can get a nasopharyngeal swab, immunoglobulin assay for IgA and IgG, and this is important. The patient who are iron deficiency anemia, they are prone to have acute otitis media, and this is not done. It is rarely done, and only done if we are suspecting some complications, right? So to summarize, the first most important is otoscopy, then we have tympanometry, then we have tympanocentesis, which is not done, and in the specific investigation or the advanced investigation, we can go with the PCR, we can go with the swab, immunoglobulin assays, and iron deficiency anemia. This slide is very important. What is the algorithm for diagnosis of ASM? If any child comes with suspected case of acute otitis media, first see the tympanic membrane. If it is bulging, yes, goes in favor of acute otitis media. Bulging and red, it is acute otitis media. If it is not bulging, then see if the tympanic membrane is opacified and if there is air fluid level. If these two things are there, but TM is not bulging, it goes in favor of otitis media with effusion, right? But if these things are not there, then these two diagnoses are excluded. Okay. So first is the tympanic membrane. If it is bulging and if it is red, clearly indicates it is acute otitis media, right? If it is not bulging but it is opacified and there is air fluid level, it goes in diagnosis of otitis media with effusion. Clear? Again, this is diagram. Acute otitis media. It is shown by a shaded red area and it share all the three characters, like the TM will be bulging, there will be medullary effusion, and this is congested tympanic membrane, right? So the main idea behind these two slides are the AOM is characterized by all the three features, like first bulging TM, congested TM, and there should be fluid behind the tympanic membrane, which is usually infected, not sterile. What are the differential diagnosis? When a child comes to you in OPD and he or she is crying, it is not always ASOM. Diagnosis can be, it can be impacted wax, there can be teething or temporomandibular joint disorder. This is very important line. A screaming child may have congested TM. So don't get confused with the only and only congested TM is there. It is not ASM. It can be seen in screaming child. Although in the congested TM there should be pain, there should be bulging of tympanic membrane, and there should be other features. Then only we call it ASM. There can be otitis externa, there can be meningitis also. The scales are very important and these are not given in books. I have prepared it from various journals. So this is the first scale is McCormick otoscopy scale. On the basis of otoscopic findings, we give some score. For example, if the TM is normal, the score is 0. If there is only erythema, congestion, score is 1. Air fluid level 2. Along with that, there is fusion 3. And like this, the score gets increased, right? In the 8th score, there is perforation, right? So this is McCormick otoscopy scale. On the basis of otoscopic pictures, we give some score to the patient. And if this score is 2 or more, then we can call it as a patient of acute otitis media. So this is McCormick otoscopy scale. The next scale is acute otitis media phase scale. In simple language, we give a chart having various emojis of the face, and we ask the parents to compare these emojis with the child facial expression, and the score is given on the basis of severity. For example, it consisted of 7 levels of symptom. First, not a problem. Second, hardly a problem. Then some problem, moderate problem, quite problem, very much, an extreme problem, right? It is more practical for the parents. It allows the parents to point to a face emoji, right, that express the child's level of discomfort. For example, if the child is having first type, there is no problem, so the emoji will be okay, normal, smiling. Then if there is some problem, and with the increase in the problem, the emoji will be changed, and according to that, we can advise the treatment. For example, if it is at the level of 1 2 3, we can ask the parent to give only this analgesic or the antipyretic. But as the severity increase, we can ask the parents to add antibiotics along with the analgesic, right? So this is acute otitis media phase scale. First was McCormick scale. Second is acute otitis media phase scale. What is the management? Now the trend has changed. Earlier there was no antibiotic, so the disease was severe. But nowadays, with the advent of these antibiotics, the change of disease from severity to the mild illness, right? Two-thirds of the children they recovered usually within 24 hours of the treatment, and 80% by 2 to 7 days with or without antibiotics. If we diagnose the patient at early stage, that can be treated very well with antibiotic and analgesic alone without any antibiotics. And according to literature, no significant difference it was found on the progression of disease, relapse of symptoms, complications, patient who received antibiotics and those who didn't, because of these scales that I discussed earlier, right? Child were treated very early on the early stage, and thus complications were prevented, and inadvertent use of antibiotics were prevented, right? And those who were taking antibiotic, they suffer double the side effect. For example, diarrhea, stomach upset, as compared to who do not take antibiotics, and there is greater risk of developing antibiotic resistant bacteria. Earlier, the funda was any patient coming to OPD with AOM, we always prescribe antibiotics. But nowadays, with the help of otoscopy, with the help of these scales, we can cut down the use of antibiotics, and thus we can prevent the excessive side effect to the child. Treatment consider depend on age of patient, compliance, adverse drug event, the cost effectiveness, allergy, spectrum of activity, the resistant pattern, and the main funda behind the antibiotic prescription is accuracy in the diagnosis. If we diagnose the child accurately, the stage of ASM accurately, we can prevent the excessive use of antibiotics, right? In the treatment, we can give analgesic, we can give antipyretic, and we can use topical anesthetic like benzocaine. We can give adjuvant therapy like decongestant, nasal decongestant, antihistaminic like cetirizine. We can have levocetirizine. The antibiotics, there are multiple antibiotics we can give to the child. The main which is used frequently, they are amoxicillin, amoxiclav, right? We can use the license cephalosporin, but there should be judicious use of antibiotics depending on the patient scenario, depending on the stage, because these are the side effects the child can have with the antibiotics, right? Now, how will we define treatment failure? If there is no improvement in the symptoms or the signs, for example, there is no improvement in ear pain, fever, the bulging of tympanic membrane, congestion of the tympanic membrane, even after 3 days of antibiotics, even after 3 days of antibiotics, there is no improvement, then this is known as treatment failure. Then we have to switch over to another antibiotics. Now, this was the guideline. This is known as Dutch guidelines for the treatment of ASM. It was decided on the basis of age and certain diagnosis or uncertain diagnosis. If the age of the patient is less than 6 months, right, we have to give antibiotic therapy in both the categories, right? In 6 months to 2 years, if the diagnosis is certain, then give antibiotic therapy. If the diagnosis is not certain, in severe illness, give antibiotic. In non-severe illness, just observation, and along with that, antipyretic or analgesic. If more than 2 years, then certain diagnosis, severe illness, give antibiotic. Non-severe illness, just observation. However, in uncertain diagnosis, give only observation. So this was the Dutch guidelines for the treatment of acute AM. This is again given in some journal, right? Again, this says if the condition is severe, consider antibiotics. If it is not severe, consider observation and other conservative treatment, right? The main funda behind all this is judicious use of antibiotics, right? This is again very very important, is again not given in books. It is known as SNAP approach. It is, the abbreviation is safety net approach to antibiotic prescription. It is an alternative form of a treatment to prevent overuse of antibiotics. It was used by England physician in which he gave prescription to the caregiver or the parents, but told them prescription is to be filled or given only if the child did not respond to analgesic or antipyretic even after 2 days or if the condition worsened. So what he did, he gave the OPD chart to the parents or the caregiver with the entire treatment, and he explained if there is no improvement with analgesic or antibiotic even after 2 days or the condition worsen, then only start the antibiotics, right? And what he found, it leads to 20% reduction in antibiotic prescription, antibiotic usage, right? So this is known as SNAP approach. This I personally used in my OPD setting. I tried this SNAP approach and the results were very good. I explained to the parents, I wrote everything on the chart, right? But I explained, start antibiotic, that is amoxiclav or some other antibiotics, only after 2 days if there is no improvement or if the conditioning, there is worsening of the condition. And I found their antibiotic usage was very, very less in patients, right? So this is known as safety net approach to antibiotic prescription. But there are certain contraindications. We cannot uh, use this approach in every patient. Like if the temperature is high grade, child is having toxic appearance, TM is perforated, AMM infection, past history of acute otitis media, symptoms are lasting more than 2 days. If known bacterial infection is there, like there is bacterial tonsillitis, bacterial sinusitis, then they caregivers are unable to get the medical facility, right? They are not able to get the facility easily and they are unable to understand, right? If the parents or the caregivers, they are not able to understand the SNAP approach, they are not able to get the facility very easily, the child is sick, the child is toxic, high grade fever, previous history of acute otitis media, then this SNAP approach is not used, then we give straightforward antibiotics, right? Now, after medical treatment, what is the role of surgery? We can do laryngectomy, we can do putting of ventilation tube, and one surgery we can do is adenoidectomy, right? But surgery has a limited role in uncomplicated case of acute otitis media, right? Myringotomy is only and only reserved in these cases. First, the severe cases where complication is present or suspected. For example, because of the pulse, there is facial paralysis. Like because of the pulse, there is labyrinthitis. Then to decrease the pressure, we'll do myringotomy. Patient is having severe pain, and when the microbiology, that is tympanocentesis, is required. For example, if we are giving antibiotics, the child is not responding, then we can go with the myringotomy. The advantage will be pain will be less, child condition will improve, the chances of complication will be less, and we can get the pulse for the culture and sensitivity. So these are the indications. It is not done in all the case, it is done in specific cases. Now, what are the management of recurrent AOM? As we discussed, the cause of recurrent AOM is genetic factor, immune factors, the biofilm. Now, what are the treatment of these recurrent cases? The first very important is alteration of risk factors. For example, the bottle feeding in semi-upright position, avoiding passive smoke inhalation, because the smoking, it disturbs the ciliary mechanism, right? And that leads to, that makes the patient or the child prone to middle ear infections. And we can advise the mother to continue the breastfeeding for at least 6 months, because that will improve the immunoglobulins levels and the immunity of the child. So these are the factors we already discussed for recurrent OM, and these factors are to be altered to prevent recurrence, right? And increase use of vitamin C. This is very important. Role of xylitol. Xylitol, it is mainly available as a sweetener. What is the role of xylitol? It is xylitol, it get convert into xylitol phosphate, and it is mainly useful against the pneumococci and the hemophilus. How? It inhibits pneumococcal growth and attachment to the nasopharyngeal cells. But how? It acts as a receptor analog for the host cells, right? Whenever xylitol is taken in as a sweetener candies, it get converted to xylitol phosphate, and it act as a receptor analog for the host cell, and thus prevent the adherence of or the attachment of pneumococci and the Haemophilus influenza to the nasopharyngeal cells, and thus prevent the infection and the recurrence of acute otitis media. The studies has shown the xylitol as chewing gums or syrup, it causes reduction of 30 to 40% cases of acute otitis media, right? So xylitol is again very important. We can use in recurrent cases of acute otitis media. It is not routinely used, but can be used in recurrent cases. Role of vaccination, we know it is usually bacterial or viral. So we can use the vaccination against influenza virus, parainfluenza virus, respiratory syncytial virus. And studies has shown the reduction in acute otitis media by 70 to 80%, right? The bacterial vaccine we can use again H influenza, Streptococcus pneumoniae, and these are the examples of vaccine. We can have heptavalent vaccine, we can have pneumococcal vaccine. The most important vaccine is against the pneumococci, because even if we are planning a patient for cochlear implantation, the pneumococcal vaccine is given. Other option, as we discussed earlier, the role of immunoglobulin. So we can give intravenous immunoglobulins, and this is very important. It is the latest thing which is given in literature. The spray of benign commensals like alpha streptococci into the nose, that will recolonize the nasopharynx, and it reduce the acute otitis media by inhibiting the growth of pathogenic bacteria, right? Clear? So this is the latest one, the spray of the benign commensals into the nose and the nasopharynx. Now, surgical prophylaxis, we can give, we can put ventilation tube or the grommet, and the meta-analysis has shown the presence of ventilation tube or the grommet versus no tube, it causes a decrease in episode of AOM by 56%, right? So ventilation tube may be useful, especially in cases of recurrent cases of acute otitis media. But what are the side effects which are associated with insertion of tube? There can be recurrent otorrhea through the tube. It can lead to chronic condition because at the site of uh, insertion of tube, tympanic membrane get thinned out, and there will be healing, and it will lead to sclerosis, tympanosclerosis, whitish patch over the tympanic membrane, and it will lead to focal areas of tympanic membrane atrophy. So it is not done in each and every patient. It is done as a prophylactic case in recurrent cases of acute otitis media, not in routine cases. We can go with adenidectomy. In a child with failed medical therapy, we can go with the adenidectomy if adenoids are the cause of acute otitis media. And the studies has shown acute otitis media, it was reduced by 31% as compared to control group in 2-year follow-up time. So in the prophylactic variety, we can go with the ventilation tube, we can go with the adenidectomy, but not in the routine cases. Now, what are the outcomes of acute otitis media? Acute otitis media, it may resolve rapidly with or without antibiotic. There can be resistant to antibiotics. That is why I explained earlier judicious use of antibiotics. Then it can persist or recur. That we explained in the subgroups, that is sporadic, persistent, recurrent, and resistant. There can be tympanic membrane perforation, and it can lead to chronic otitis media. And last, if not treated well, it can lead to complications. Clear? What are the long-term consequences? The most important and most significant, it is hearing loss. It can be conductive hearing loss, it can be sensory, it can be mixed. Whenever the child has conductive hearing loss, it is usually temporary or transient or permanent. But whenever there is SNHL, it is permanent. And this is the question which is asked in practical exam. What is the cause of SNHL in acute otitis media? It is spread of infection or the product of inflammation through the round window membrane into the labyrinth, right? In chronic otitis media, the cholesteatoma is causes destruction of labyrinth. There can be labyrinthine fistula that I discussed in my last class. But in case of acute otitis media, it is not destruction. It is absorption of the toxins through the round window membrane into the labyrinth that leads to SNHL. And make it clear, whenever there is SNHL, there is involvement of the toxins into the labyrinth. It is usually permanent. So the early diagnosis and the treatment is the key to prevent this permanent loss. Another sequelae, once we gave antibiotic to the child, the acute otitis media, the fluid becomes sterile, right? But there is fluid, and that in the later stage it can lead to convert into effusion, right? And later on it will be complete atelectasis of tympanic membrane can be there. Because of the decreased hearing, the child may have speech and language development that will affect expressive language, not receptive development. Expressive, right? So these are the sequelae. There can be hearing impairment in the form of CHL, SNHL, or both. There can be middle effusion or the atelectasis, and there can be speech and language developmental problem, right? So these are the chronic sequelae of the acute otitis media. So what is the take home message from this lecture is, this is very important topic for theory exam, right, as well as practice, and as well as the OPD, right? So the take home message for the treatment of these patients is this: cut down the gift antibiotic resistance, cut down the gift of antibiotic resistance given to a patient from our side by the judicious use of antibiotics. And this can be achieved only and only with the very important is otoscopic examination, right? It should be done very nicely in the OPD. We should be able to identify the stage of ASM, and accordingly we should be able to treat the patient. It is not like a patient is coming to OPD with a congested TM and straightforward we write the antibiotics. These are the patients who can be very well treated with the nasal drops, antihistaminics, analgesic and antipyretic. Keep antibiotic uses only for later stages, right? And the scales, these are very important. We can use in our OPD settings. With the help of these scales, we can know whether the child really requires antibiotic or not, right? So this was the lecture which I made from these books and various journals. So this is all regarding ASM. So any questions? From which age we start? So one question asked is from which age the antibiotic prescription should be started. It is, see, the one criteria or the one guideline that I explained was Dutch guidelines, right? It should be mainly on the basis of clinical presentation of the patient, not on the age, right? If the child is having bulgy TM, child is having fever, child is having congested TM, irrespective of age, we should advise antibiotics. But if the child, irrespective of age, there is no congestion, only mild congestion is there, no bulging, no fever is there, these are the patients who can be very well managed with the antipyretic and analgesic. So the antibiotic prescription is not related with the age, it is related with the clinical presentation of the patient, right? Any other question? Will there be temporary bulging in case? Will so the next question which is asked is, will there be tympanic membrane bulging in case of OME? Right. In OME, in the initial stages, there is collection of fluid, right? So there can be slight bulging, but how will we differentiate between AOM and OME? In AOM, the TM will be red, it will be bulging, right? But in OME, the TM may be bulging, but mainly it is retracted and there will be no congestion, right? So main tympanic membrane finding in OME is retraction, because the fluid in OME, it is very thick. It causes retraction of the tympanic membrane towards the middle ear. So the TM is usually retracted instead of bulging in OME. Why there is retraction OME when there is fluid in? Again same question. Because the fluid in otitis media with effusion, it is very thick. Later stages, it gets, there is uh, formation of bands between the tympanic membrane and the middle ear. If this is tympanic membrane, this is middle ear, yeah, and there is fluid, thick fluid, it causes formation of bands between tympanic membrane and the middle ear. So there is retraction of the tympanic membrane because the fluid is very thick. And I have done laryngectomy in OME patient. The fluid is very thick and it is very difficult to suction this fluid. So what we do, we flush the middle ear with the normal line. That will make the fluid thin and it will be easy to suction this fluid later on, right? This is the cause of retraction in OME. Any question? Will be diagnosed. Oh, points to differentiate recent perforation and the old one. See, the recent perforation, the TM will be congested, the perforation will be congested, and usually in case of acute otitis media, the history will be short. Starting from the history, it will be short, right? On examination, the margin perforation will be small, the margins will be congested, the rest of the tympanic membrane will be congested, and there can be discharge over there. However, in the old perforation, the margins or the all remaining tympanic membrane, it will be not congested, and usually it is bigger in size as compared to the smaller one in cases of acute, right? And we can get a X-ray, mastoid or CT scan done. With that, we can identify whether this is recent. In the recent one, there may not be sclerosis of the mastoid hair cell. However, in the chronic cases, there will be sclerosis of the mastoid hair cells. Any other question? Any role of topical antibiotics? See, usually the topical antibiotics are not very useful in acute otitis media because the main, if the TM is congested, it is bulging, the mainstay of treatment is your oral antibiotics, your analgesic, your antihistaminic, and nasal drop, nasal decongestant. Topical antibiotics are usually not given, and if it is given, like in cases of perforation, we can use ciprofloxacin, plain ciprofloxacin, or along with the dexamethasone, we can use ear drops. Any other? Sclerotic mastoid and sclerosis due to disease process will appear. Yes, see, in sclerotic mastoid and sclerosis due to disease, there will be difference in the CT scan. If the mastoid is sclerotic, the other side, we will compare to the other side, right? If the sclerosis is same on the disease side, it may be due to, it may not be due to disease, but if it is due to disease, there may be sclerosis mastoid. Along with that, we can find some soft tissue density inside the middle ear, inside the attic, and thus we can identify whether this sclerosis is because of the disease, or it was earlier also, it is not related to the disease. And we should compare always and always to the other side, so that we can compare between the two, right? Valsalva in AM, it should not be done in acute otitis media in active stage because there is infection and it will cause severe pain, and it will may lead to spread of infection, more spread of infection. It should be avoided. But it can be done in cases of acute otitis media with effusion when the fluid is sterile and there is no pain, right? It can be done in effusion cases, but not in cases of acute otitis media. Instead of that, we can use nasal drops like xylometazoline, oxymetazoline. We can use these drops that will decrease the edema of the station tube opening, right? But avoid Valsalva maneuver because it can lead to severe pain, the spread of infection, right? And even it can lead to rupture of the tympanic membrane when the first point is there. Like as I explained earlier, the yellow point and the nipple side. When it is there, it can lead to rupture of the tympanic membrane. So it should be avoided in acute cases. Any other? Still, we can use terms like ASNC, and some books says it is AOMNC. Yeah, see, my last lecture was on the categories of otitis media. Whenever we say it is nowadays, instead of ASM, we are writing A. Instead of CSM, we are writing CM. It is almost same thing because sometimes there is chronic otitis media. It is without pus. There can be otitis media, like whenever there is cholesteatoma. It is not pus, but there can be otitis, that is infection because of the cholesteatoma, but there is no pus. Then it is known as chronic otitis media. That is why the term has been replaced CSM with the COM and ASM with the acute otitis media. Thank you, ma'am. Thank you, ma'am. Role of steroid. Yes. See, steroid should be kept only and only if there is no improvement, right? As I told earlier, that cases of treatment failure, like in cases of the patient who are not responding to your routine antibiotic, you have changed the antibiotic, there is no improvement. Then if there is suspected, like if the child is having severe pain, it is not responding, then keep these steroids only for those cases. although it is not routinely advocated, not routinely given. These are the patient, they get very well benefit with the antibiotic. See, if we diagnose the patient very early at the stage, then there is no even there is no use of we can prevent the advertent use of antibiotics. So steroids are, the role is very limited, and they are kept only for failure patients. I have myself used this SNAP approach in my OPD, and results were fantastically very good. Many patients, they get benefit with the simple and very simple analgesics, and there was no need to give antibiotics to this patient. Even with the use of analgesics and with the needle drops, they get benefit. Steroid nasal spray, yes. Steroid nasal spray, it is again, it is debatable. It can be used, but in cases of recurrent AOM, not in routine AOM. Recurrent AM, with the cause is your adenine hypertrophy is there, right? If there is allergic cases are there, nasal allergy is there, sinusitis, means the cases in which the AM is secondary to the main cause. Nasal allergy, sinusitis, adenoiditis, nasal polyposis. In these cases, we can use steroid nasal spray. But the best nasal drop is your saline nasal drop, because that maintains your mucociliary mechanism, right? It makes the secretions thin, it makes the clearance very good. So steroids, the oral steroid, the topical steroid, they are kept only for the recurrent cases. They are kept only for the cases when there are etiology factors like adenoiditis, nasal allergy, or sinusitis. Any question? Child comes with ear pain and rhinitis, throat pain. Rhinitis, throat pain, will have to give analgesics only with antihistaminic drops. If there is fever, then only, yes. See, the main indication for antibiotic is if the child is restless, child is having severe pain, child is having fever, then only use antibiotics. Otherwise, try to manage these patients with antihistaminic nasal drops and analgesics. Again, I'm repeating, I have used this method in my personal experience, that and these childs, they get benefit with these simple analgesics, right? How to take decision regarding grommet insertion after laryngectomy. See, studies have shown the results of your steroid nasal spray. The grommet is mainly useful in cases of otitis media with diffusion. In AOM, it is mainly laryngectomy without the use of grommet. Grommet in AOM is only and only done in recurrent cases, right? The first. So studies have shown even in OME, the steroids have a very good role, and it is replacing your grommet, right? There are some side effects of grommet insertion that I have already explained. It can lead to chronic otorrhea, recurrent otorrhea, that it may the acute otitis media may convert to chronic otitis media. It may lead to tympanosclerosis, and it may lead to atrophy of the tympanic membrane. So it should be done if the child is having bulging TM, severe pain, and suspected complication. To release the pressure, to prevent the complication, we can decrease the pressure, but just by doing the laryngotomy, just by giving a nick in the tympanic membrane, in the anterior inferior posterior inferior quadrant. No need of putting the grommet. It will release the pressure, and the child will feel better, right? So we should avoid grommet insertion in acute cases. The laryngotomy will be sufficient. how long we can treat AOM with medical before considering laryngectomy. Okay. Again, there are certain indication of laryngectomy. If the child is having recurrent AOM, then we should look for the various factors like iron deficiency anemia, the immunoglobulins, right? And the role of again biofilm, right? The immunity of the child. So uh, we should focus on these risk factors. We should alter these risk factors. We should boost the immunity of the child, and with that we can prevent the recurrence of episodes of acute otitis. And nowadays the vaccines again against RSV, the influenza virus, and the bacterial vaccines are also available to prevent these recurrent episodes of acute otitis media. Any doubt, any question? Is there any antibiotic of choice? Yes. See, main antibiotics we can use, this is amoxiclav or cephalosporin group, right? These are the antibiotic of choice in these patients, acute otitis media. In case of children less than, okay. How to differentiate AOM from meningitis? See, AOM is a, it is a group of symptoms. There will be pain, there may be fever, there may be severe pain, there will be decreased hearing, and on examination the TM will be congested, TM may be bulging, and we can see the specific sign like cartwheel appearance, we can see the nipple sign. But in case of meningitis, these associated symptoms like fever, the severe pain, decrease in, it will not be there. In meningitis only and only we can see the congestion or the some granules, it is like granulations over the tympanic membrane. These associated symptoms will not be there in meningitis. Topical antibiotics in resolution stage. Yes, we can give topical antibiotic resolution stage, but as I told earlier, main role is of oral antibiotics. We have to treat the infections. If we continuously keep on using the topical antibiotics, the tympanic membrane perforation, it will not heal, right? For the healing of the tympanic membrane, we should keep the ear dry. We should keep the patient on oral antibiotics, antihistaminics, right? And thus we can prevent the formation of permanent perforation, which is epithelialized margins of the perforation. So thank you all. I think we should finish this session now. Thank you everyone.
Thank you all training faculty members for joining this session.